All right. So, anybody that complains of shoulder pain, be mindful that it is not coming from the neck. Normally, neck pain is up here, and they'll talk about pain in the neck here as well, okay? Anytime, and they say neck pain, make sure you ask, where in the neck are you hurting? Okay. Here is almost always like cervical TPIs or trigger point injections because this is more muscular and trapezius related. When we're talking about shoulders, there are either two things going on. Number one, you either have arthritis in the shoulder, or number two, you have some sort of rotator cuff problems, okay? The way that you know it's arthritis is if you take this shoulder, put your hand on top of it, and you move it around, you'll hear crepitus. You'll hear, things just like moving around in there, and you're like, that doesn't feel normal. So that is indicative of just arthritis, okay? And for that, you would just do an intra-articular shoulder injection, okay? The next thing you would do is do a physical exam on the shoulders as well. Hey, go ahead and bring it all the way up. Good range of motion. While I've got you, go ahead and flip this down both ways. This is called an empty can test. It's like you're spilling a can, making it empty. You hold it up here, strong. Good job. So if one side flops down, that means that there is a tendon or a muscle issue in the rotator cuff. Usually the one that, for an empty can test, if it's drops, that means that you have a suprascapular or supraspinatus tendon issue, okay? There are 4 muscles that attach to this rotator cuff. If one of them is gone, it can give you pain here. And it can give you the drop arm, okay? Number 2, the other test that you can do is what we call a Hawkins and a Neers test. See, that test would be positive of an impingement in the actual shoulder joint. And when you see that in any sort of rotator cuff pathology is where you do the subacromial bursa injection, okay? Subacromial means below the acromion, there's a little area that gets inflamed. So folks that have this positive, or they have what we call the empty can positive, they've developed some bursitis in that area, and we can treat that with a bursa injection. So, intra-articular and bursa injection. Here you can get what we call a lateral epicondylitis in the elbow, so you push right there and they will scream. That's seen classically in tennis. Folks that play tennis, you'll get that. And then the medial one is medial epicondylitis, which is golfers. People that play golf, you'll see medial epicondylitis there, and that's for elbow discomfort that they're having, okay? Then you come down to the fingers, hands. Anybody that complains of numbness and tingling in these 3 digits and this side here, that's consistent with carpal tunnel syndrome, okay? That's the medial nerve that comes out here and it innervates this area right here, and that can give you carpal tunnel. Number 2, you can also have ulnar neuropathy, which is the nerve that comes out from right here, the funny bone right underneath it, that can get entrapped and give you pain here as well. So those are 2 things that you want to be mindful of when it indicates just wrist and hand pain, okay? Numbness and tingling here or here. And if they're like, oh, it comes out, it shoots down here and it goes here, that's likely coming from the neck. One of the tests to do to see if they have a disc herniation is to do a Sperling's test. Sperling's is when you extend it, take it in one motion, hyperextend, and then push down. And if they're like, wow, that just gave me shooting pain down the arm, that is consistent with a herniation in the neck, and that's where you would do a cervical epidural steroid injection. Same thing here, you push down, push, and that gives them the shocking feeling. You may have a disc herniation possibly as well. So that's that. That is the upper extremities. Any questions?
I thought there was also a median nerve that goes here.
That's the one we were talking about, which is
radial and then ulnar, and then
medial is in the middle, yes. And medial nerve is responsible for carpal tunnel syndrome that innervates these 3 fingers and right here. So that's if you're thinking it's median nerve, it comes over the aponeurosis, fibrosis right here. And this is the area why you get carpal tunnel is there's a little area, just like we have plantar fascia at our foot, same thing up here. That area can get irritated and inflamed and give you the median nerve symptoms. Again, median nerve is these 3 fingers, the ulnar nerve is these 2 fingers, okay? Questions?
With the ulnar neuropathy, what injection do we do?
Yeah, so you can do an ulnar nerve at the elbow. You can do an injection right here, which is different than the medial epicondyle. So for the medial epicondyle, you're going actually into that joint right here that I'm squeezing. Then ulnar nerve comes on right here. You'll do an ulnar nerve injection at the elbow. Ulnar nerve injection at the elbow, right here. Right where my finger is, okay? So good question. And a lot of people don't have a lot of fat, or they're like bony, like I am, like in that bony nerve can get irritated right below that. So just be mindful of that, okay? Good question.
Thank you.
Yeah. Again, let's talk about the neck here. So for the neck itself, again, the 3 things that you're thinking are either, is it nerve related, meaning does it shoot down the arm? It can be either arm. Then you know we need to do an epidural injection, okay? And for epidural injections, there's only one type of injection you can do. You cannot do a transforaminal. Obviously, you cannot do a caudal because caudal is all the way at the bottom. You can only do a C6, C7, or a C7T1 interlaminar ESI, meaning either of those 2 levels are what you can target, okay? Here is T1, C7, T1 is right here, and then C6, C7 is right here. Anything higher than that, you do not want to do an injection because you're going to be too close to a vertebral artery, okay? But it's the safe area to deliver the medication. Even if they have problems or a disc herniation at C2, C3, C4, C5, C5, C6, we can still inject it at C6, C7, and the medication travels up and down. Do you understand? It's not just localized to that area, okay, where the meds go in. You cannot do a transforaminal injection in the neck because there's a big artery there, okay? The other thing you can do is an occipital nerve block, where you block the nerve right here and right here. And oftentimes folks would be complaining of pain much higher in this area. And you take the mastoid and the occipital protuberance, where this little bony part is right here, and you split the difference right there. If you push and they're screaming, that's occipital neuralgia, okay? All right, so we've covered the neck, shoulders, hand, arm. Oh, the other thing that we commonly do, so there's only 3 options that you have for the neck. Either you can do an epidural injection, number 1. Number 2, you can do a muscle injection. And number 3, oftentimes we get arthritis in this area. And that arthritis presents itself when you take your head backwards, and they're like, wow, we cannot do that, or they have very limited range of motion. He has excellent range of motion here. Normally, the patients that have developed arthritis cannot extend like this at all. So, and that would be localized more to the center. More of the pain is localized to the actual neck here and not going down. Again, if it's going down or going down the arm, that's an epidural. If it's right here in the muscles, it's a muscle injection. And if it's only here, then it's likely a DMBB or a nerve block that we do. And then up here is the occipitals. Okay? Next. We talked about all that. Yeah, go ahead, please.
With the cervical DMBB, would you recommend we send Valium every time we do cervical DMBB?
Yeah, I think so, because most people, great question, yes, most people are quite tender in that area and it's very sensitive, so yes, I would do it I would just start doing it across the board for cervical DMBBs and cervical RFAs, okay, because those things are quite painful. All right, next thing is, we're coming...
Would you do it like weeks or months after, or are you talking about just the pre-procedure Valium.
The pre-procedure.
Oh, the pre-procedure.
Yeah. Just for pre-procedure. We're
Yes,
not
sir.
talking like, we don't prescribe Valium.
That's
here.
what I thought, yeah.
Yeah.
Yes, sir.
Okay. We'll turn around here. In the mid-back, folks that complain of pain that's wrapping around and shooting across, a lot of times it may be shingles-related pain, and so you want to ask that question. Or if they've had like some sort of a fracture in their spine, it may irritate the nerve that comes across. So for those, we commonly do both of those reasons. We do the epidural injection. If it's shooting across, it's numb, tingling, we do epidural injections. If it's localized to the spine, right in the middle, okay, not to the sides, this is more muscular, right here, this, but in the middle itself is where you develop arthritis. Just like you can do a DMBB here, you can do a DMBB right in the middle as well, okay? To target any of those thoracic and lumbar areas that are causing localized pain. The difference is that people will say, hey, for the DMBBs, it's more very central, but for the muscular pain, it's more on the sides, just barely, okay?
And question, the level for in the thoracic level for DMBB versus ESI, I always have trouble identifying the level.
Yes. So very easy to identify the level here. I take the spine of the scapula, so take his spine right here. This is the scapula, you see it right there. And that automatically right there, middle is T7, okay? Up here, the top of the scapula is T4. So you already know 4, 5, 6, 7, 8, 9, 10, 11, 12. So you kind of have an idea, and as you know, when we do DMBBs, we're covering like T8 to 10, T7 to 9. We're covering 3 different areas, so that way, for example, like right here, if he was like, my pain is right here, right in the middle, there's 7 right there, I would do 7, 8, and 9. Make sense? Or it's like, my pain is up here, I would do, T4, 5, and 6. Makes sense? And it's always good to examine the patients without the shirt so they can see. You'll get a much better picture as well, okay?
And is that level is the same for ESI?
Yes, it is. Yes, that is correct. Yes, it is the exact same. If you notice here, it's the exact same. So if they're complaining of pain right here and shoots across, when it comes across to the front, T4 is your nipple line is T4, and T10 is your umbilicus or belly button line. So anything between that, so it's 4, 5, 6, 7, 8, 9, 10. 10. Okay? 11, 12, 1, and then it goes down. Makes sense? And we have a very good visual here. All these pictures here show that. So T10 is the umbilicus here, belly button. T4 is the nipple line. So you can kind of count down. This is the front. Okay, look at this side right here. This is the front. And on the back side of the patient, the T7 is the spine of the scapula. Here's the scapula, and the T7 is right at the base of it.
Okay.
Okay. Good questions.
Thanks.
Yeah. All right, next thing is we're going to come down to the lower back now. Turn around for me here. Same thing in the lower back. When it's right in the middle there, that's more of a DMBB. More on the sides is muscular. Anytime it's muscular, they will jump off the table and they'll be very sensitive, okay? Number 1. Number 2, if they're complaining of pain down lower and it's on the sides, that's the SI joint, okay? Sacroiliac joint on the sides here, okay? If it's right in the tailbone, a lot of people have
Caudal.
caudal, exactly. Right lower, like right between the butt crack there, that is coccygeal or coccydynia, and you do a coccygeal nerve block there. Okay?
Yeah.
So SI's on the side. And let me show you him. And turn around one more time. Let me just show where he's at. Just like this is where it is, like that, right? And so when they're complaining of pain on the sides, that's usually the SI joint. If it's right in the dead center, that's the facets. And then if it's on the sides, and if it's superficial, that's more a TPI or a trigger point injection for the muscular component. Okay.
I always like to feel the SI joints because
Yeah.
then I know where L5 is. I know where the posterior, superior iliac.
That's right.
Uh-huh.
The other thing you can do is if you take your fingers and put it right over the iliac crest, you're at L4.
Right.
Let me
right.
show you another picture here. So if I take this area and I put my hands right here, there are my fingers right here and right here, L4 is what I'm touching right there. L5 is right below it, and the SIs are below it. So you put your hands on every patient is the key, and you'll realize hip or pelvic area, that's right at the iliac crest is right at the L4. Okay. Next, we talked about muscle injections. 3 things you can do in the lower back as well is trigger point injections, DMBB, nerve, which is a nerve block, and then epidural injections. In the spine or in the back there are actually 3 things you can do in terms of epidural injections, okay? One is a transforaminal approach. The transforamen means between the foramen, you can get some pain in this area here, and it causes a disc herniation. So you go after it, and you got to read on those MRIs. If it does say that there's foraminal narrowing, which means the foramen is narrowed and it's on only one side, then you would do a transforaminal approach, okay? If it says there's a disc protrusion or a disc herniation and there's no mention of like foraminal narrowing per se, then you can do like an interlaminar epidural steroid injection, okay? Alternatively, there's caudal approach, and that's generally if the patient has had like L5-S1 surgery or you're trying to get to the S1 nerve root, you do a caudal approach, okay? There is, you can do transforaminals as well in the S1 nerve root, but generally if the symptoms are bilateral, you want to do an interlaminar ESI or a caudal ESI, and if it's unilateral or one-sided, then you want to do a transforaminal. Okay? Yeah.
One question for you too,
Yeah.
actually. And something you'll see on MRIs is sometimes they'll have a disc protrusion in the central, and they'll say it's catching a nerve root going down. You want to document that, so that'll give you a level. What's your take on if it only has one single level? So say they say at the L4-5, there is a central disc protrusion hitting the L5.
Right.
Do you do an L4-5 and an L5-S1?
Yeah, it's a good question. That's a very good question. So if it's unilateral, then yes, I would do it because, again, you have to know your anatomy, and you'll know that the nerve that exits, let me show you this picture right here. It's between L5-S1 is L5, and so what Dr. K was just saying is that when you have a disc that's protruded right here, and they mentioned that it's impinging upon the L5 nerve root, if you do an L4-5 epidural injection, you're not going to cover that nerve root, okay? Sure, you'll cover a little bit of it, but that's not what you want to hit the 100% mark, and you want to do it as correctly as possible. So you want to go over the area where the nerve is. So you would do an L5-S1, and if it's unilateral, then you would just go ahead and do an L4-5 and an L5-S1 transforaminal approach. Does that make sense? Do y'all follow, or is that? It takes years to comprehend this, by the way. It took me many years.
Can you repeat that one more time?
Yeah,
Sorry, I didn't.
sure. No, sure. So when you have a central disc herniation at L4-5, okay, and it'll say L4-5 central disc herniation.
Right.
Do me a favor. Can you draw out the central versus lateral and how it impinges the nerve? There's a very good drawing, and I'll send it to you when I remember. But it shows where the disc herniation is where the nerve root will be impinged. And it's all because the nerve roots exit for L4-5, they exit right above that L5, and so depending on where the disc herniation is, you may not have any issues or any problems at L4, for example, because where the disc herniation is irritating the nerve below that. Okay? So there's a really good picture. Oops, sorry. There's a really
so
good.
basically, what you're trying to say is, if you have a central disc herniation at L4 and 5, most like the L5 nerve roots will be affected.
Yes, and for that reason, you have to do an L5S1 instead of doing an L4-5, because again, that disc herniation that's there is messing up the nerve that's at L5. So you got to go after the L5 nerve root.
Understand.
Yeah.
So if you have,
that's a good picture.
so if you have a spine like this, you have L4, L5, sacrum. If you have L4, you have this disc in between two vertebrae. They'll say a central disc herniation, which then means right here.
Yeah.
Okay.
Good. You can mark it on there. Yeah, mark
Yeah,
right there.
so
So central. So
is
you can
right
see.
here.
Yeah, great picture. And you see that nerve is already exited. The L4 has. So the L4 is not going to get affected. L5 is affected.
Which means that, you're on video. Which means that to catch the L5, you need to be at this level.
Yeah.
So you can get that nerve root.
And
if
then,
there's pathology here, you can still just do a transforaminal here, but you need to get that bottom one too.
Yeah.
Okay. And the keyword we're looking for is it central canal stenosis?
Central canal or central disc herniation.
Yeah. Anything central pathology.
Yeah. Central pathology.
Okay.
And then if it says foraminal, the foramen are right here, and so it'll say L4-5 and L5S1 foraminal stenosis. That means these nerves, draw the foramens here, please. The foramen on the sides is...
So you just have like an opening here.
Yeah.
Superior articular process, the inferior articular process.
So the foramen is right here, and that opening is where that nerve root comes out of. So if there's an L4-5 that's impinged, then it'll affect the L4 nerve root.
Understand. So if it's a transforaminal, if it's a foraminal stenosis, the nerve is at that level. But if it's central canal stenosis, it should be the nerve below that level.
Yes. Yeah, you can think of it that way.
Yeah. Took me years.
I see.
It took us years. It took us years.
Took me 30 seconds, Tweet. That's impressive.
So that's what that's for. Lastly, just to wrap up here, the last thing I just want to mention is the knees. Knees, there's 3 things we can do, now 4 actually. So you can start with an intra-articular knee joint injection. If you have and for those, I don't really need an x-ray or anything. I just, physical exam, you hear popping and crepitus, they've got arthritis in there. You do a simple intra-articular inside the joint steroid injection. If the pain is, if they've had previous surgery before, you try to do a genicular nerve block. A lot of times insurances don't cover that, so look at the paperwork, the checkout form to confirm that. Number 3, you can do what we call hyaluronic acid injections, which is Suparts. For that, you generally want to do the steroid injection first, unless the patient's like, oh, I've already had steroids, and you just do the series of 5 injections weekly, starting the week after. Okay?
You don't need an X-ray.
You don't need an X-ray for that. Yeah, and generally our templates have getting approved without the X-rays. Right.
Because I thought it has to be primary osteoarthritis.
Our physical exam of crepitus in 60-year-old lady, that's arthritis. I don't need to waste money and x-rays and time to prove that, period. Number 3, or the 4th thing that you can do, so 1 is steroid injection. The second thing was the genicular nerve blocks. You can even do that for people that haven't had surgery, but again, the insurance is the biggest limiting factor. But just make sure it's not one of those that's not covered on the checkout form you can see. The 3rd thing is Suparts or Synvis, those hyaluronic acid injections that are the cushioning ones. Okay, and then the last thing is PRP, and PRP is generally reserved if they've gotten an MRI done already and you see that there is a partial tear, the ACL is partially torn, the posterior horn is partially torn. And that lady we saw this morning was a classic case of doing a PRP versus even a steroid. All right, any questions?
No.
Okay, all right. I've recorded this. I'll try to send this electronically for y'all to view. And thank you for your time, and I'll see y'all soon.
Thank you for having me.